So today we're thrilled to have Dr. Michael Mann, Professor of Surgery in the Division of Adult Cardiothoracic Surgery at UCSF, that's University of California in San Francisco. Dr. Mann received his medical degree at Stanford, followed by a residency at Stanford and Brigham and Women's Hospital in Boston, that's Harvard, guys, and at UCSF. I made a little script here. He's not only a talented and a skilled surgeon, he's a researcher as well, with special interest in molecular biology of sarcomas, biomarkers and molecular profiling of metastasis, clinical management and pulmonary, clinical management of pulmonary metastasis, evolving techniques for minimally invasive chest surgery, just to name a few. So with that, I'm going to welcome Dr. Mann, and thank you for talking with us today. Virtual clap.
Well, Sharon, thank you so much, not only for that very, very kind introduction, but also for this opportunity to connect more with patients. And, you know, in this day and age, information has become such a valuable and just, you know, irreplaceable commodity. But the quality and the quality control on information is, you know, sometimes so tenuous. And, you know, I often remind patients in the office that even the fellows who come to the operating room with us to learn how to be specialized chest surgeons or specialized sarcoma surgeons have spent anywhere between 7 and 12 years, you know, with their heads poring over this scientific information and medical information after graduating from medical school. So to expect patients to be able to absorb the same type of information from the same sources is so unrealistic and in so many ways unfair. And yet we have such little time in the office to really try to convey the enormous wealth of information that is exploding now across all fields of cancer, all fields of biomedical science, really. And so I really do appreciate this opportunity to spend a little quality time just talking about the clinical science and a little bit about some of what we call translational science to understand how all of that relates to each person's individual situation, which is, you know, in the end, what every patient really needs to know. So without wasting any more time, I'm going to try to share a presentation that I developed for this talk, for this webinar. And I also am not a Zoom aficionado, but I will try my best.
Just a reminder, everybody should mute themselves, please. Thank you.
But Sharon, can you all see this, the presentation that I've tried to share?
Perfect.
Great. Okay. So I am a surgeon, and of course, every specialist brings their own particular perspective to the work that they do and the way they view the world and the field. I've always felt that surgeons had a particularly important role in biomedical science because, unlike many scientists or even internal medical doctors, surgeons are incredibly impatient, and we need an answer and we need a solution as soon as possible, often within seconds in the operating room. But that impatience and that need for, again, quality information and quality decisions, I think drives us to sort of push the limits and push our fields of research a little harder and sometimes a little faster. So today, though, we're going to be talking primarily about clinical science, about how the field of surgery can impact this entity of leiomyosarcoma, and dive a little bit into some of the research that we're doing and that, of course, other labs around the country and the world are also trying to do to try to catch up, to be honest with you, what's known about the molecular biology and cancer biology of this particular disease compared to, I'd say, the field of cancer in general, where we have so much information that we're really trying to understand how to understand that information and integrate it. And for a disease like LMS, of course, we're a little behind the curve just because we don't have as many patients to study. And a very important problem that, of course, Sharon and her important organization are addressing, the need for more attention and more funding, because it is a competitive world out there, and breast cancer, lung cancer, colon cancer are going to grab most of the attention. So it's great that folks like Sharon are stepping in and filling that void to bring more resources to bear on still a very, very important entity, which is LMS. So in good academic form, I don't think I have anything to disclose with regard to either the clinical care that we provide for LMS patients or the research that we're doing. This is sort of how I organized this particular talk, but I'm glad you have the chat box. Do jot down any thoughts that you have. It's a little harder in this context of our distanced interaction to have a very spontaneous discussion, I guess, during the presentation, but I really hope to leave as much time as possible for your questions and for the interaction so we can hone in on the issues that you folks would really like to address. But this is how I structured the presentation that I'll provide right now. LMS, of course, is a subcategory of what we refer to as soft tissue sarcomas. They're all rare. All sarcomas are relatively rare cancers, and LMS is just a subgroup of that. But we'll look at some of the unique biology of soft tissue sarcomas in general, because many of it does relate to leiomyosarcoma. And the biology actually provides definitely some challenges for patient care, but also some unique opportunities. So we'll address both of those. We'll talk briefly about chemotherapeutic options for LMS. Doesn't warrant a long conversation, unfortunately. And then dive into surgery. Surgery for primary tumors, I think, is fairly straightforward. So I think Sharon has asked me to focus today on a different problem that many, many LMS patients face, which is how to deal with metastatic tumor that spread from the primary site, whether it was in the arm or the belly or the uterus. They all find a common final pathway for too many patients in metastatic disease, spread of the disease to a distant organ, and in general considered a very ominous development for many cancers, but there's true reason for a lot more optimism in sarcomas in general and LMS as well. So I want to focus on that and make sure people are aware of those opportunities. Okay, so again, diving in, the more boring slides are all up front, so they'll get a little more visually attractive, at least, as we progress through the talk. But I thought it was important just to make sure we're all on the same page with some fundamental concepts about sarcoma and LMS. So as I said, they're rare cancers, and there's probably a reason for that. Most cancers are derived from tissues in the body that are constantly replicating their cells in normal life. The linings of organs in particular are exposed to the environment to a certain degree, more or less, and so they naturally are subject to cellular trauma and turnover. Sarcomas are tumors that derive from what we call the connective tissues. So these are not the tissues that are normally exposed to the environment, and tissues that very often don't replicate themselves very often in normal life. So therefore, it makes sense that it would be a more rare event for these to have deranged growth as cancers manifest, but also means that their biology is going to be somewhat different. There are going to be different factors pushing these cell types into the realm of malignancy, into the realm of cancer. As I mentioned already, one unfortunate corollary is that there are fewer people studying sarcomas as well. There's fewer patients out there to study, fewer tissue samples to study. So the explosion that I referred to in terms of our knowledge about cancer is a little smaller, but still, compared to what we knew before, a lot of new information that we need to integrate. One thing I thought I'd just touch upon is that because sarcomas are rare, the typical community hospital will not see a lot of sarcoma in a year or even a decade. And so I do believe there's some real benefit, if it's possible, if it's feasible, to try to get the care of sarcoma patients into centers where there is a lot of sarcoma being funneled. So places like UCSF, where we have a very robust sarcoma center, but they are scattered across the country, not always easy to find, but they're out there. We talked about the unique element of sarcoma's origin, and therefore their cancer biology is a little unusual. From a patient's perspective, one of the most bothersome traits of sarcomas in general, and LMS is certainly one of those, is that they have a higher rate of what we call local recurrence, which means that after the original tumor is removed, we can get that tumor to grow back in too many patients. And there are a few reasons for that we think we understand. There's more extent of microscopic elements of the tumor into the adjacent tissue that's impossible to detect, and therefore can be impossible to remove in the operating room during the first operation. But I want to focus today on another aspect of sarcoma, which causes trouble for patients, which is this concept of metastasis, or the spread of the cancer. In sarcomas, it's almost always through the bloodstream as opposed to the lymphatic system. And the practical corollary of that is that there are fewer metastases into lymph nodes than for many other cancers. Breast cancer is probably the most famous example where the lymph nodes are so important. Lung cancer as well. For sarcoma, we don't see it in the lymph nodes too often. It can happen, and it does happen, but all sarcomas tend to metastasize first to the lungs before they go anywhere else. So the lungs are a very, very important place to screen patients with a known sarcoma for evidence of metastasis. But an unusual part of sarcoma biology that honestly we still don't really understand is that very often sarcoma will spread only to the lungs. And that's going to be a huge focus of today's webinar. So when sarcomas do spread from their original location, they can leave just microscopic deposits in the lungs. And it's not clear, again, why the lungs in particular. People have offered physical explanations. The lung is a filter, as well as the place where all the blood is exposed to the oxygen in the air. And so it's sort of the first place that all of the blood runs through after a cell might enter the bloodstream. But it's not clear that that's really enough of an explanation. So there's clearly some sort of molecular cell biology disposition, I'll say, for these sarcoma cells to settle in the lungs. But what we also don't understand that's very, very important for patients is that these microscopic deposits can sit in the lungs for weeks, months, or years. And we not infrequently will see a sarcoma patient who's had no evidence of metastasis for a decade after the original tumor was removed, and then suddenly they've got metastasis, again, usually in the lungs. And so we have learned to be very, very aggressive about surveillance in the sense of screening the lungs of sarcoma patients, even 10 or more years after their tumor has been removed, even if there's been no other evidence of disease. Because what we don't want to happen is for a tumor to have a comfortable time of growing and growing and growing unnoticed. The lung is a big open space. It's essentially a balloon. And so a tumor can grow to be very, very large without causing any symptoms. And so the only way to detect this phenomenon early is to screen the lungs. And the CT scan is an outstanding modality for that, because the lungs are air. So any tissue will have a different density from the normal lung. And that's exactly what CT scans can detect. So we can detect even a millimeter or two of growth, abnormal growth in the lung. And as I hope we'll touch upon in the talk today, early recognition of this and early diagnosis is really a key element, because we do have good tools to deal with metastatic sarcoma in the lungs, but it's really important that we find it as early as possible. That keeps the most number of options on the table and usually the best options. The aspect that's important here about sarcomas and LMS sometimes only spreading to the lungs is that if we have a contained disease process, we can think about it as a surgical target or a target for any local therapy. Local therapy meaning very focused therapy on a specific site in the body, as opposed to systemic therapy in which we put a drug, sometimes a targeted agent nowadays, sometimes just a poison, into the bloodstream to kill tumor cells wherever they may be located throughout the body. It's a good approach when you don't know where tumor cells might be lurking. In sarcoma, we don't have great systemic drugs. We don't have great systemic treatments. And so to be able to turn metastatic disease in sarcoma back into a local disease where local treatments may be effective, we're actually bringing the word cure back onto the table. And that's what I want to emphasize really more than anything today. All right, so because the spread of sarcoma is often contained to the lungs, it really changes the rule books. When we see a lot of metastatic lesions in other types of cancer, we get very pessimistic because we think it's a widespread process, a process that we'll have trouble controlling locally, certainly, and maybe trouble controlling with systemic treatments. But in sarcoma, because even a large number of metastases can still be anatomically contained within the lung, there's not the same need for pessimism right up front. And what our research has shown at UCSF, and I'll show you a little bit of these data, but at other places as well, is that the number of nodules of sarcoma that start to grow in the lungs does not necessarily predict the degree to which this disease is truly lurking. So let me say, there are many metastatic sarcoma patients whom we can't save, and I think that goes without saying. And very often it's because there's just an overwhelming amount of disease burden. But what I want to emphasize here is that that ultimate burden of disease is not necessarily reflected in the number of nodules that crop up way at the beginning of the process. And that's what I mean when a patient presents to us for the first time with a diagnosis of metastatic LMS or metastatic sarcoma in the lungs. We can't take the number of nodules that we see right at that beginning of the process as necessarily an indicator of how bad it's going to be over the course of time. So the other element here that you see on this slide is that recurrence is common, and it's unfortunate, but it's a fact of life that we deal with in sarcoma, and it's not necessarily the end of the story. So as I said, these cells can sit in the lungs for years without showing their hand, without letting us know that they're there, and then suddenly start to grow. So if you have these deposits in the lungs, and only some of them are growing, when we first diagnose the disease, we can only treat the ones that we see, the ones that we can detect. And unfortunately, we don't have a method yet of detecting these things on the molecular level. One day we will have a blood test that tells us, whether these nodules are present, but we don't at this moment. And so these tumors really do have to grow to be big enough to be detected. And so it is very common that we'll remove sarcoma nodules from the lungs and not realize or not know that we're leaving behind microscopic deposits that are absolutely undetectable. So recurrence is quite common. But here's the key. When that recurrence happens, if we can clean out the lungs again, patients can do very, very well. And I'm making a big deal about this because this is very, very different in sarcoma compared to other types of cancer. And I have a few slides later on in the talk so I can explain a little bit more about why that's true. But for now, take it as fact that our ability to continue to clean the lungs of metastatic sarcoma is a huge weapon that we have against the ultimate fate of the disease. and does give us the opportunity to look at patients who can have a very long course of survival after the diagnosis of metastatic LMS or metastatic sarcoma. And I dare say, really cure patients, even if they have not only metastasis, but recurrence of the metastasis itself, particularly if it's limited to the lungs. Another element that has become more true in the past decade, I think, is that we can use a multimodality approach to really optimize the care of these patients with metastatic LMS, but also recurrent metastatic LMS. And again, we really need to take advantage of everything about the lungs that helps us. The fact that we're born with much more than twice the amount of lung that we need to survive on this planet. So, we've been given a lot of lung to work with, which allows us to take out bits and pieces of lungs here and there and everywhere and still leave patients with pretty normal breathing capacity. It means that we have to be very careful when we do remove tumors, that we leave the uninvolved lung alone, because there may be some other a nodule that crops up in some other part of the lung that we're going to have to remove further down the road. But as I mentioned a little while ago, the CT scan is a wonderful modality to detect this disease early, because all we need to do is identify the edge between a dense sarcoma nodule and that lung, which is really made up of air. Okay, so most of what I've just been talking about is true of soft tissue sarcoma in general. Leiomyosarcoma is a little bit unique among soft tissue sarcomas, unfortunately, because it can tend to be more aggressive, I'd say, than the average sarcoma. But everything here is a huge spectrum, so needs to be taken with a grain of salt. What does that mean? Well, for the purposes of this talk, it means that we do see spread of the disease a little more often. And we do see both lung, pulmonary, and extrapulmonary spread of LMS a little bit more often than we do, I'd say, in other types of soft tissue sarcoma. So that doesn't mean that everything I've been talking about with this great opportunity to control lung metastasis is off the table. Far from it. It means that we need to be a little bit more conscious about surveillance for other parts of the body. And we need to be sometimes a little bit more multimodality, in the sense of bringing more of a team of surgeons to consider what's feasible, what's possible to control metastatic disease. Because the fundamental principle is still the same. The diverse array of locations where LMS shows up is, again, I think, more limited than many carcinomas, the more common types of cancers. And so there is still a role for aggressive surgical control of metastatic LMS, even if it goes beyond the lungs. So we need to keep all of that in mind. Just to be complete, I've thrown in a little bit of information about the complement to surgical treatment of metastatic disease, which of course is systemic therapy. And for sarcoma, we're pretty much still in the realm of traditional chemotherapy, certainly for LMS. There's some degree of response of the disease to certain chemotherapeutic agents. Many of you may have heard of these, with your own course of dealing with the disease. Doxorubicin is probably still the mainstay of chemotherapy for LMS. And sometimes we add another drug called ifosfamide to give it a double punch. It's very common in cancer care to combine chemotherapy, chemotherapies that have different mechanisms. But again, in recent years, I think we've appreciated that another drug called gemcitabine, and again, in particularly when it's combined with an agent, a family of agents called taxanes and docetaxel in particular, can also have very dramatic responses in individual patients. And again, we don't have yet the molecular tools to predict which patients are going to respond in this dramatic way to the drug. So very often it's a trial and error process. But we can see some dramatic responses. And even in patients with a lot of metastatic disease, I've had patients who've been treated with gemcitabine and docetaxel. Their CT scans look remarkably better after treatment. We bring them to the operating room, and sometimes we find that the nodules that we take out are all dead, so that the gemcitabine and docetaxel has really wiped out the metastatic disease. Unfortunately, it's not the majority of patients. So we still have a ways to go in perfecting our treatment of this disease. Understatement of the century, perhaps, but we're on the way, and we have a few tools in our armamentarium. And again, before I jump into the surgical data that I'm going to share with you, some of the quote unquote classic data here about the chemotherapy of LMS. And you can see these are survival curves. So the way you can interpret it is this is the percent of patients on the y-axis who are surviving over time on the x-axis. And the fact that it drops down is not a good thing. So these are all patients with advanced disease, metastatic disease. And you can see that this is all of these patients had chemotherapy. So there's no untreated group here. The blue line is the combination of doxorubicin and ifosfamide. So a little bit better, but not really much better. And really no change in the long-term prospect for survival. But what we've learned is that by combining these drugs, we do get a better response early on. So you can see we've doubled the quote-unquote partial response rate, and we've halved the progression rate, so that by combining these drugs, we can get some improvement in outcome. But the take-home lessons is that doxorubicin can extend survival of this disease compared to no treatment at all. The combination is probably more effective at delaying the recurrence of the disease. So you get more control, of how quickly the disease progresses, but not really better long-term control by combining those two agents. With gemcitabine, we really do, I think, get better long-term results by combining it with the taxane. And again, the most common one is docetaxel. And again, these are graphs from a classic study that really established, among others, the benefit of gemcitabine for certain patients. And you can see, again, progression-free survival means that you haven't gotten that recurrent tumor yet. Overall survival means you're still alive. And so we do see actually a benefit in both cases for combining the two drugs together versus one drug by itself. So a little bit of progress, but as I mentioned, it's the minority of patients who will have this really great response to gemcitabine. On the other hand, every patient responds to surgery, not always with the perfect outcome, but this is the difference between surgery and medicine I alluded to a little earlier in terms of mindset and attitude. Surgeons by nature need results, and they need to see them right away. And fortunately, that has led us in sarcoma and LMS to a pathway for treating what otherwise is often considered kind of a hopeless situation. And just to digress for a moment, I mentioned the concept of the center of excellence, and for in medicine in general, it tends to be true, but for sarcoma, it's really true because the oncologists in the community just don't see this very often. And I can't tell you how many times patients have come into our sarcoma center, in my office in particular, having been told they're in a clinical situation that has no options. They have metastatic sarcoma, metastatic LMS, and it's going to take their life, and there's not really much that a doctor can do about it. And very, very often, that's just not the case. There are, again, we can't save everybody, but there are definitely many patients with metastatic sarcoma for whom surgery is a real option and an effective option. It may prolong their life like chemotherapies do, but it may actually take the disease off the table for them. And so, again, we can't promise that to every patient, but it's in a center like ours where there's a lot of experience that analysis really ought to take place. And in UCSF, for example, how do I explain this? Every hospital, or almost every hospital that treats cancer, has something that they call a tumor board, where the cancer doctors get together once a week or once a month and discuss either all the tumor cases or the most difficult tumor cases. And it's a multimodality approach where you have a surgeon, an oncologist, a radiologist, radiation doctor, et cetera, all to pour their expertise into one decision-making process for a recommendation. At UCSF, as do some sarcoma centers around the country, we actually have a sarcoma tumor board. So we have a tumor board that just focuses on sarcoma. We have a dozen or more cases, sometimes 24 cases to discuss on a weekly basis. So there's a wealth of experience and then a wealth of exchange of knowledge and information that goes on in a setting like that. And it doesn't help every patient, certainly doesn't save every patient, but it certainly increases the opportunity for benefit. So that's my little pitch for trying to guide sarcoma patients once they've gotten through their initial phases to a sarcoma center. Now, across the world, we've learned that surgery for metastatic sarcoma makes sense for all the reasons that I've already mentioned. But I'd say at UCSF, we've taken a particularly aggressive stance towards metastatic sarcoma. And several years ago, we published some of our earliest findings that stem from this very aggressive approach that we had taken over the previous decade and a half. And these are just some of the results that we published in those studies. Most of them are quite consistent with what other people have published, but I think we pushed the envelope a little further and we're able to make a few additional observations. These are the characteristics of the patients whom we studied. You can see about 150 total metastatic patients over that period of time, 120 of which had single or multiple resections of their metastatic disease. So again, this is not total sarcoma patients. These are just the ones that came for lung surgery. And you can see in our experience that LMS makes up the biggest single proportion of those patients. It's about a quarter of all patients, but you can see certainly compared to some of these other types of sarcoma, much more common in our surgical practice for metastatic disease. And it goes along with what we said about LMS being a relatively aggressive form of sarcoma. And so metastatic patients are certainly going to show up quite often. Though across the board, sarcomas have a pulmonary metastasis rate in the 30 to 40% range. So that's quite substantial no matter what type of sarcoma we're dealing with. If you look at some of the other elements here, on average, the patients had about 2.5 years between the time of their initial diagnosis of sarcoma and the metastasis. You can see half of these patients, or almost half of these patients that came to surgery, had disease in both of their lungs. So again, just a reflection that we still treat patients with metastatic sarcoma even if they have a fairly significant burden of disease. Look at this: a third of all these patients had more than 4 tumors in their lungs, and some of them had 20 or more tumors in their lungs. And you can see there's a wide distribution in terms of the size of the tumors on both ends of the spectrum. Let me just jump back. A lot of patients have very big tumors, but a lot of patients only have tiny tumors. And the tiny tumors can be a little bit more daunting because it can reflect a more widespread process. It's actually worse to have dozens of tiny tumors than to have a few really big tumors, because the really big tumors are easy to get out. But when you have too much disease spread all over the lungs, it does limit what we can do, certainly with surgery or radiation. This other element here is this concept of extrapulmonary disease, meaning disease outside the lungs. So you can see it's a relatively rare, but certainly not unheard of phenomenon in general, and certainly therefore in our practice. So this is the overall survival curve for this entire cohort of patients. And again, it drops down, so that's not a good thing. But this is years here, not months. And so you can see that our 5-year survival rate for metastatic, these are all metastatic patients, is around 40 to 45%. So that's pretty darn good for metastatic cancer. But look at what happens to this curve. When you get out to 10 years, it's still around 30 to 35%. So, and not all, but a lot of these patients are older, so they're dying of other things. And so there really is an opportunity, even with metastatic sarcoma, including LMS, to get ahead of this disease and to stay ahead of it. The curve on the right of the screen here reflects, again, that difference that I brought out between patients who have disease limited to their lungs, where we can achieve these better long-term outcomes, and patients who have disease outside the lungs, because it may reflect a more aggressive course and may reflect, something that's harder to control surgically. Again, that's all comers. In LMS, there's I think a little bit less of a disparity between those two curves. And so we looked at factors that would influence prognosis so that we could tell a patient right up front, well, what are you looking at? Are you looking at the side of this spectrum where we're going to stop this disease in the operating room, even though it's begun to spread, or where we're going to have a harder time doing that? And the only one factor that really sifted through all of the noise in our experience to tell us that these patients truly have a more difficult situation is when the metastasis is diagnosed at the same time as the primary tumor. So those patients, not all of them by any stretch of the imagination, but among those patients are more patients who have a more widespread, more aggressive process. If we diagnose the metastasis anytime later in the course of managing the original sarcoma tumor, the prognosis is not as poor, and also unrelated to that interval, at least according to our statistical analysis. So it's really an issue of whether or not the metastasis is present at the time of diagnosis. Extrapulmonary disease outside the lungs, looked like it might influence prognosis when we did the simpler, what's called single predictor the analysis where we're only looking at one element at a time. But when we put that together in what's called a multifactorial analysis, where we eliminate kind of the confounding interrelationship of these factors, even that fell away from statistical significance. So again, we think, with our growing experience, that this gives us a lot more reassurance that an aggressive stance to this disease is justified. Because if patients who have many, many lesions were just doing very poorly after surgery, it kind of draws into question whether surgery is really the right answer for those patients. But if it doesn't predict a bad outcome and we're able to control the disease, then it certainly justifies a more aggressive approach. And these are just some of those observations that we made. So since it's so common for patients with pulmonary metastasis to recur in the lungs, we've actually undertaken another study where we looked at sarcomas and non-sarcomas to ask this question of, how justified is it to bring these patients back into the operating room or to subject them to a multimodality approach to treat these lesions in the context of metastatic disease that's recurred. So in non-sarcoma, we only operate on metastatic disease if we think the patients are in a really favorable prognostic group. If we think that their metastatic disease is really quite limited, sometimes we refer to that as oligometastasis, meaning very few metastases. And so the patients who come to surgery for non-sarcoma are a different class of patients, because we don't aggressively bring all patients with metastasis to the operating room the way we might for sarcoma. So these are two very, very different patient populations to begin with in terms of their metastatic disease. But we've done a lot of this surgery at UCSF, and you can see we were able to compare two large groups of patients, ones with metastatic sarcoma, and again, Leiomyosarcoma, again, the single largest group in that cohort, to patients with other types of cancer that also have surgery for metastatic disease. And we looked at three different types of outcome, or I should say we looked at outcomes of overall survival with three different groups of patients. Patients who never recur, patients who have disease that comes back but that we can resect completely, and patients who have disease that comes back and we have no surgical options at that point because the disease is just too widespread. And that's an important distinction. Again, don't need to look at too many details of this study, but you can see sarcoma patients tend to be younger They have very often more aggressive spread of the disease to their lungs, but again, often only to the lungs. And they tend to have less extrapulmonary disease, again, as we've talked about. The disease-free interval, that time between primary tumor diagnosis and metastasis, is shorter for these sarcoma patients, again, because we're more aggressive about getting all of these metastatic patients into the operating room. So first, the patients with other types of tumor. The blue line are the patients who don't recur. So obviously they have that best possible prognostic situation. So these are patients who undergo surgery and it doesn't come back. The green line are the patients who have disease that comes back, but we have the opportunity to remove the recurrent disease from their lungs usually. And so, so how do these patients compare with other types of cancer? Well, at first they seem to do better, and that may seem totally counterintuitive or paradoxical. Why would these patients be doing better, having better survival early on? That's what we call a survival phenomenon. So these patients have to survive long enough to get a recurrent lesion. So this is a statistical anomaly, really, that this is, again, what I talked about, how different factors can confound and confuse, just a simple observation. So, this is that survivor effect, that patients have to live in order to get a recurrence. But what happens over time is that the patients with recurrent disease, even if it's resectable, clearly do worse than patients who've never had a recurrence. And this is, again, non-sarcoma. Well, what about sarcoma? So again, you see this statistical anomaly that the patients with recurrent tumor seem to be doing better early on. But again, just a statistical phenomenon. But look at the end of these curves and how they differ over time. So if we're able to clean out the lungs a second, third, or fourth time, and patients recur only with resectable disease, there's really no difference from that blue line where patients never recurred at all. So again, it's not 100% survival, but it's a big enough difference that it certainly justifies taking the options for treating that disease quite seriously. And whereas on the non-sarcoma side, you might say, well, is it really worth subjecting these patients to additional surgery? But on the sarcoma side, it looks like it really is, a valuable strategy. And so it's very difficult to sort of derive these data even from relatively large cohorts. So this was one of the first glimpses that I felt that we had from our own research to tell us that, yes, we're on the right path here in being fairly aggressive, even when the metastatic sarcoma comes back. Now, I mentioned the word multidisciplinary a number of times. That just means you're bringing in different doctors with different specialties into the picture. And there is an option outside of surgery for local treatment of metastatic sarcoma. And I think specifically stereotactic body radiation therapy, or Sbrt, is a very reasonable and effective modality. Many of you have probably heard that radiation is not very effective in terms of curing sarcoma. Sometimes can be used to slow down or prevent local recurrence, which is due to, again, microscopic disease that's left behind. But what's interesting about Sbrt is that they've taken really an ingenious approach that sort of undoes the huge Achilles heel of radiation, which is that we have to limit the dose of radiation to a tumor by the dose of radiation that the rest of the body can handle. And traditional radiation treatment just sets a radiation beam at the patient's body. But with Sbrt, what they've done is they actually can move the radiation machine around the patient so that each beam of radiation that gets sent out of that machine can come from a different angle. So that allows the radiation doctor to break that total dose down, not into just 30 doses based on 5 doses a week for 6 weeks, but into many, many dozens and sometimes hundreds of doses, and just delivers each dose from a different angle so that the surrounding tissue, the normal tissue of the patient's body, only sees one of these tiny little beams, but everything, focuses and collapses down onto the tumor. So the tumor gets a massive dose where all of these beams converge, but the surrounding tissue gets irrelevant dose of radiation. And so that allows the radiation doctor to deliver a massive dose of radiation to a tumor, and it can be very, very, very effective. And we've had probably one of the biggest experiences at UCSF combining Sbrt with surgery for the treatment of metastatic LMS and metastatic sarcoma, especially in the lungs. And we've learned a lot about the outcomes. Now, there is some side effect of radiation pneumonitis, but you can see only 5% of patients have that type of reaction in their lung. So for most patients, there are no side effects at all, no fatigue, no discomfort on the skin. But we are limited by a few things. It's not a perfect panacea. The size of the tumor is important. We can surgically remove a big tumor from the lung, but we can't treat a very, very large tumor with this technology. And we can't treat a very large number of tumors because, as you can imagine, those unique pathways, those unique beam pathways for the small doses of radiation are going to start to overlap if you do that many, many times in the same lung. But what Sbrt can provide beautifully is an additional non-surgical option for those patients who have a recurrence that's quite limited. So many patients can have 5, 10, even 20 lung nodules removed in their initial surgery, and then they show up a month or a year or 5 years later with just one more nodule. And it might be a big deal to have to go back and reoperate on that patient, but Sbrt can offer a non-surgical option that can be just as effective. 95 to 98% of the tumors that we've treated with Sbrt have been cured at UCSF. So it is when we can use Sbrt, it is very effective at the individual tumor level. And these are some of our outcome data. So you can see on the left side of the screen that the patients who have just surgery and who don't have stereotactic radiation as part of their treatment have a little bit better disease-free survival, especially early on, because in the operating room, we can remove tumors that you can't see on a CT scan. The finger is actually the most sensitive technology that we have still today for detecting nodules in the lung. And again, because the lung is essentially air, we can also feel these tumors very sensitively in the operating room. So we can get more tumors out of a patient than we can treat just based on the CT scan with stereotactic radiation. But you can see that doesn't affect the long-term survival. And this is crude clinical science. So, take this with a grain of salt. These are very, very difficult studies to do. This is not randomized prospective research by any stretch of the imagination. But in our crude attempts to try to match these patients up, using stereotactic radiation along with surgery doesn't seem to be any worse when we can do it than treating patients with surgery alone. If there is a take home from this research, from this curve, that's what it is. And then just to reassure you that although resources are a little more limited for sarcoma, we certainly are trying to push the envelope. We are doing the same type of molecular research for sarcoma and LMS as is being done and moving the bar up for the treatment of many other types of cancer. And in our lab at UCSF, where we have a lot of samples in our research lab of metastatic tumors, as well as primary tumors from the same patient, we're able to really look at the molecular biology of that metastatic disease. And one of our driving hypotheses is that there is a unique identity and a unique profile at the molecular and genetic level within a tumor for those few cells that have the potential to cause a metastasis. We believe that the majority of tumor cells don't have that metastatic potential. So if we can identify the molecular elements of that personality, if you will, of that profile of an individual tumor cell that makes it capable of metastasis, that we might be able to target that process and prevent metastasis at the molecular level, or at least at first diagnose the likelihood of metastasis in a patient who's presenting with a primary tumor. And so this is just some of our earliest research published last year by comparing the molecular genetics of metastatic tumors to the primary tumor from the very same patient. And you can't do this with a lot of types of cancer because we don't usually operate on the metastatic disease, but because we operate on so much metastatic LMS and metastatic sarcoma, we have more of this tissue to work with and to compare. And we started off just looking at the entire genome, looking for differences in expression of particular genes. And we honed in on about 50 or 60 genes that looked very differently expressed in the metastatic tumors compared to the primary tumors. Again, looking for clues as to what makes a cancer cell within a tumor capable of creating a metastasis. And we focused in on 2 of those gene candidates out of the 60 for a number of reasons. First of all, when we went to a broader array of patients, and here you can see, I think, about 35 different patients with all different types of sarcoma. Even in our lab, any single sarcoma subtype, unfortunately, is not representative in large enough numbers, so we pooled the sarcomas together. But you can see over a wide array of different sarcoma types, and there are a few of the LMS patients here represented. We saw a very consistent pattern of increased expression in the metastatic lesions compared to the original tumors, the primary tumors. And so we looked at these genes and the proteins that they encode. So what are they? KRT7 is part of that, what we call cytoskeleton, the part of the cell membrane that gives it shape, that gives it kind of a firm functional status, and therefore plays an important role in the movement of cells. Migration, and also adhesion of cells, how cells stick together. MUC1 is another gene that is involved in what we call this cell adhesion, cells sticking together. It's actually a protein that's expressed on the surface of cells and has a lot to do with cell-cell communication. So it can be involved in interaction of a cell with the immune system. And of course, a metastasis has to escape the immune system in order to survive in an alien environment where it's not protected by its other tumor cells. But it also has a lot to do with interaction between cells and this concept of adhesion, of cells sticking together. And you can imagine for metastasis, these cells have to be able of breaking apart and migrating and invading. So it makes a little bit of sense that these 2 genes may be important in that process. So one way that we looked at these 2 genes in sarcoma cells is to scrape the cells growing on a petri dish and to watch how the cells migrate back toward each other. And so you can see the untreated cells here have quote unquote healed this wound completely within 48 hours. But when we used a trick to block the expression of these 2 genes individually here in these sarcoma cells, you can see that they never healed during that same time frame, and it's certainly a slower healing process. And you can see the inhibition of that tumor migration, of that cell growth, cell invasion of the surrounding environment as it's quantified there. But what was most exciting to me about this part of our research is that we went back and looked at our patient population. And remember, we identified these genes just through kind of a statistical analysis of many different samples. But here what we did was on an individual patient level, we said, does the level of expression predicted all the outcome for the patient? And lo and behold, we found that there was a statistically significant correlation, even in our small sample size, that patients with very high expression of both of these genes did have much worse outcomes compared to patients that had a much lower level of expression of both of these genes. And so it doesn't prove anything yet, but it says that this may be both a good way to diagnose patients much earlier in the process, who is going to have aggressive metastatic disease and who may be spared that. It may tell us who to be more aggressive with in terms of treating metastatic disease because their prognosis is better. But my hope is that it may also be pointing us in the direction of maybe a novel therapy in which maybe we don't cure the primary tumor by targeting these proteins and these genes, but maybe we can prevent the phenomenon of metastasis by targeting these genes and these proteins. And how exciting that would be, you know, to achieve this goal of turning sarcoma into a chronic rather than a lethal disease. By inhibiting the process of metastasis, which very, very often, you know, is what leads to the demise of any patient with this problem. So I think that wraps up my presentation. Again, talked a lot about the clinical scenario, why surgery can be a very relevant form of treatment, even for metastatic LMS, and why there's justification to be fairly aggressive about that. There's also justification for combining surgery with a special form of radiation that can, again, I think, help prolong life for many of these patients and improve quality of life. And we're on the way. We're working towards better molecular and cellular understanding of the disease, which, of course, ultimately we hope translates into a better approach. Until we know how to treat everybody, we have to take it on a patient-by-patient basis. And that involves, very good surveillance and really interpreting each patient's pattern of disease to try to do the best that we can with what we have in the year 2020. So I've eaten up an hour.
Wow.
If folks would like to hang on and ask some questions, I'm very, very happy to entertain those.
And people can also unmute themselves and go ahead and ask questions. My first one is, in a surgery, what is your record number of Mets you've removed?
So great question. Comes up in the operating room, when we're training our fellows and our residents. I joke that at UCSF, the pathologists labeled the specimens A, B, C, D. And usually that's perfectly adequate. But early in my career, I noticed that, we were operating on a lot of little tiny tumors in patients' lungs. And I wondered what would happen, when we got up to Z. So it turns out the largest number of nodules from a single lung in a single operation that we've taken out at UCSF is about 27. And the pathologist just went to AA to answer that question. But that's obviously very unusual, but it's not unusual to take a whole bunch of nodules. And again, many of these are very tiny. So we've also figured out ways using minimally invasive surgery so that we don't have to subject patients to a long recovery period. Also makes it easier to go back and reoperate once you've done, what we call this minimally invasive approach of VATS, or video-assisted thoracoscopic surgery. But we've also figured out how to take out the least amount of lung surrounding the tumor so that we do get a margin. But you probably heard, many of you have heard, that for sarcomas and LMS, when we take out the original tumor, we want to get as big a margin as we possibly can to prevent that recurrence. Fortunately for us, when the disease is growing in an alien environment like the lungs, it does tend to ball up, and they don't tend to have as many microscopic tentacles. So we don't need a huge margin. So we do try to spare the surrounding lung so that we can take out more lesions. And just as important, have a lot of lung to work with down the road if it crops up in a completely different part of the lung. The patient's going to rely on the remainder that we left behind. So
you want to look at the chat box there and see if there's questions?
Yes, getting populated. So I'll just run down from the top. So deciding between surgery and SBRT. Yes, even the minimally invasive surgery involves pain and discomfort. It's one thing, the only thing a surgeon can guarantee a patient is pain. So that we almost never avoid. Sometimes we don't get the outcome we want, but we always cause some discomfort. And so SBRT seems like a very, very attractive alternative. But SBRT does not give you any opportunity to interrogate the lung and to do what I told you the fingertip can do, which is find those occult lesions that you can't even see on a CT scan. You also can't treat these tiny lesions with SBRT, even if you do see shadows on the CT scan. Whereas, it's very easy to get multiple lesions out if they're small during a single operation. So that's why I say I do believe there's a difference even at the beginning, that we get better disease-free survival with surgery because we can clean out the lungs a little more effectively than we can with SBRT. So surgery is almost always the first choice, unless the patient has, reasons why surgery would be more dangerous. But SBRT is great because then we can often spare patients reoperations, which by their nature are always a little bit more difficult. And very often we'll see a lot of lesions at first, but then only a handful of lesions down the road when they recur. So that's a perfect scenario. also there's a limited number of SBRT treatments that a patient can have in their lifetime. So sometimes there's this idea in managing patients long-term that we want to hold on to that card because there may be a lesion that actually is not amenable to surgery, or that surgery would be very, very morbid. And we want to have that SBRT option left to use. So that's another reason why we might elect surgery when it's more feasible.
We have a saying on our Facebook group, when in doubt, take it out.
Yeah, well, and that's a tenet of surgical training, of course. But good surgeons, you know, spend most of their careers learning when not to operate, which is also very, very important. I'll just run through these questions, perhaps. Margins are clear. Does that mean that microscopically clear? So yeah, when a pathologist says that margins are clear, that does mean on the microscopic level. However, pathologists look at 5 microns at a time. A micron is a millionth of a meter. Okay, so 1,000th of a millimeter. All right. So even a small nodule is often, you know, a centimeter in diameter. So a centimeter is, you know, 10,000, what is it, times bigger than a micron. So the pathologist is not going to be able to look at every micron of the margin. Okay. So to the degree possible, and using, you know, a statistical sampling approach, yes, it does tend to mean that a good margin means that microscopically the edges are clear. But it's certainly possible to have a microscopic deposit that just can't be accessed by the pathologist because it's literally impossible to look at every micron under the microscope.
Thank you.
And the same is true of primary, you know, margins as well as metastatic margins. Are there any improvements? Well, not really, not yet. We're hoping to get molecular markers that can, you know, you've probably all heard about the frenzy toward what we call liquid biopsy, which is kind of just a jazzy term to mean that we take a blood test and we're hoping to detect something in the blood that tells us something about a tumor, and in some cases about a tumor that we don't even know exists. But for LMS, we're not quite there. To be honest with you, for almost any tumor, we're not quite there. It's a great idea. It's sometimes based on the fact that tumors shed genetic material into the bloodstream, and we're able to amplify genetic material. We're able to amplify DNA with PCR, and we're able to amplify RNA by converting it first into DNA. And so we can learn about tumor gene mutations, and also sometimes about tumor gene expression if it's really abnormal compared to normal cells. But we don't have that yet available. So I said, fortunately, the CT scan is effective down to about 1 millimeter or 2 in terms of sensitivity, because most of the lung is air. And so we got to take advantage of that, at least for metastasis to the lungs, which again is most of the story for sarcomas and LMS. So tumor board votes for no surgery. Would you get another opinion? It depends a little bit on the nature of the tumor board and the hospital. At a place like UCSF, where we have a sarcoma tumor board and crazy surgeons like myself, you know, weighing in on most of the cases, if a tumor board like that really thinks that surgery is not a good option, you have to take that, you know, very, very seriously. If a community hospital has a tumor board where they don't see a lot of sarcoma, you might ask for a referral to a sarcoma center, where there's just, you know, a little bit more of experience, and maybe they can pick out elements in a patient's clinical course that might make them maybe a little bit more hopeful of a surgical option. But, you know, sometimes we also, I didn't mention this in the talk, but sometimes we use chemotherapy as a litmus test, because we don't want to operate on people who derive no benefit from the surgery. Like I said, it's inevitable morbidity, and in a small number of patients, even mortality from the surgery. And so if we're going to take that risk, there really ought to be a real likelihood of benefit from it. And so very often patients with a lot of metastatic disease will have chemotherapy, and we're looking for some suggestion of a response. If the cancer blows right through that chemotherapy and there's really no improvement in the degree of metastatic disease with the chemotherapy, sometimes that gives us pause about going ahead, and it's very individual. If we still think that surgery is feasible and it doesn't look like progression is going to overwhelm the patient shortly after surgery, we may still recommend, going ahead with surgery in the absence of a good chemotherapy response. But a lot of centers have used that as a litmus test to see, in a patient with more widespread disease, whether surgery should even be contemplated. So it is a complex question. And I'd say, if you get to a good sarcoma center where there's a lot of experience, the opinions are probably quite valuable. Under what circumstance, we talked about Sbrt versus lung resection. So if anybody still has questions, please feel free to ask. But we learn a little bit more from surgery. So even if they're both feasible, sometimes we'll lean towards surgery. Again, with minimally invasive surgery, it's about a 2-week recovery period. So it's not dramatically different in terms of, the recovery from both of those types of modalities. Definitely more painful to have surgery. But it's a matter of balancing the long-term strategy. Thoracotomy versus VATS. Great question. So it used to be a dictum that you had to do thoracotomies for metastatic disease because it was the only way to feel the lung with your fingertip. Minimally invasive surgery in the belly is all done with long instruments, and you only touch the tumors with a stick. You only touch the tissue with a stick in the belly. But in the lungs, is a different situation because we don't need to use pressure to prop up the rib cage. It's a rigid structure that gives us a natural cavity to work in when we collapse the lung down to operate on it. And so we can stick our fingers into the lungs, and because the lungs are floppy balloons, we can actually bring the lung to the fingertip. So even if your finger doesn't go all the way across a patient's chest, you can pretty much bring any part of the lung up to the finger. That's now big barrel chested patients or patients, who are very heavy, sometimes that's limited. But in most patients, we can feel most of the lung with our fingertips, even doing a VATS approach. And so less and less do we think we need to revert to a thoracotomy. I would say in my practice, I will convert or go with a thoracotomy when I think I need to do a very intricate resection, perhaps of lesions that are really deep in the lung. And we can't just staple across, but we have to really very carefully carve and identify multiple lesions from very sensitive locations in the lung. That's still hard to do with a VATS approach. So I'd say that's the most common indication in my practice for thoracotomy. Is the presence of a nodule a reason for surgery? Oftentimes, it's not so much the presence or absence of the nodule, but it's the pattern. If there's an overwhelming amount of nodules throughout the lungs, it may be impossible to remove all of them and still leave lung behind for the patient to breathe comfortably. And the pattern of progression. So if 1 month we see a certain number of lesions and then 3 months later we see 2 or 3 times as many, that's not a good sign for a surgical approach, because 2 or 3 months after surgery, you're very likely to see more disease and with very limited surgical options at that time. So it's more about patterns than about a static picture or a yes or no. So liver mets. So that's an important issue for LMS. I'd say oftentimes more often than with other types of sarcoma, unfortunately. And again, we have great belly surgeons, general surgeons who focus on sarcoma at a center like UCSF. So very often we're collaborating. We're often at the tumor boards together, and So yes, we do operate on metastatic LMS in the liver, and we can combine that with surgery for the lungs. The key, I think, for the treatment of any metastatic cancer is that you have a global plan for the patient. So the primary tumor, there's a plan to control the primary tumor, and whatever metastatic disease you're aware of, there's a plan to treat it. And if you're only going to palliate certain parts of the disease, then it may not be, worthwhile to have an aggressive, definitive approach for other parts of the disease. So again, all the pieces need to fit together. But it's certainly the case that there are many patients who have both their liver mets and their lung mets operated on. So one of the participants is asking about the testing for these genes. So this is still, in the translational realm. It hasn't been translated yet into clinical practice. So I don't want to mislead anybody into thinking that we've proven that there's a clinical role yet for looking at the expression of these genes. Tantalizing as it may have been on the screen a few moments ago, that degree of research does not justify any clinical interventions or even analysis at this point. If we can expand that research to much larger numbers of patients and really get a better handle on how it reacts, then we might develop a more clinically relevant way of testing for those genes and intervening based on that. But so there's no standard testing for these genes. And remember, what we were comparing was the level of expression in a metastasis versus the primary tumor. That's very hard to do, unless you happen to have those tissues available in your laboratory. So we really want to translate this to more of an absolute level of expression in any given tumor. And that's very different from what we've been able to research so far. So I don't want to mislead people into thinking we're even further down the road than we really are. But this is certainly the first step in identifying molecular targets. And these two genes may end up being targets. Okay, next question is about not having been offered surgery and having undergone both Sbrt and chemotherapy. Low burden still. How does Sbrt work with surgery? Well, they're very compatible. One thing I like about Sbrt, you might also have heard about other ways of quote unquote ablating tumors or trying to destroy tumors without making an incision and going into the body surgically. When I've seen those different modalities used in lung nodules, the other modalities that use heat or cold to destroy tumors tend to stimulate a much bigger inflammatory reaction, which can make just a bigger mess inside the chest. To be a little crude in my terminology there, but it does make things a little messier and harder then to operate in the future. Whereas Sbrt in general is a very clean modality. The tumors just involute and die. There's much less of an inflammatory reaction. And so Sbrt and surgery do go together quite well. They don't influence each other very much. If there's a low burden of disease, it may very well be amenable to surgery. But again, depends on the location of a particular patient's lesions and a lot of individualized elements. So, maybe something to pursue with a second opinion. But in general, Sbrt and surgery certainly can go together quite well. So by surgery, did I mean VATS? So if there are small nodules that are being watched, what does that mean? So lung surgery can mean VATS, or it can mean open surgery. Another question mentioned the word thoracotomy. That just means we make a bigger incision and spread the ribs apart so we can get our hands in the chest. So I think the meat of this question is Sbrt vis-a-vis the size of a lesion. And it is true that very tiny lesions are not necessarily good targets for Sbrt. And so we sometimes do wait to see a lesion mature. It gives us also the luxury of sort of having a crystal ball, which is, that lecture that I slept through in medical school that I always regret. Not having a crystal ball, limits our ability to know, which treatment was really the most important. But when we are able to watch a lesion, it will declare sometimes for us how aggressive it's going to be. Though I do caution that with sarcomas in general, and LMS certainly as one of those, the pattern of growth in the past does not necessarily predict the pattern of growth in the future. So for the reasons that we've kind of touched upon, microscopic cells can remain dormant and then start to grow, but cells can start and stop. And so a lesion could reach a certain level, stay there for months or years, and then suddenly start to grow again. So, if a nodule is growing slowly, it's certainly a better sign than if it's growing very quickly, from the get-go. But to get back to this question about Sbrt, it is true that sometimes we wait, and especially if there are multiple lesions, there is a limit to the total number of lesions you can treat with Sbrt. And so you may want to treat just those lesions that are destined to grow. And one way to know that is to watch them. Let's see. Biopsy. Well, you always want to establish a diagnosis before you invoke an aggressive morbid therapy, any dangerous therapy. So, but sometimes lung nodules, if we're so suspicious that it could be related to metastatic sarcoma, we might not rely on a negative biopsy, to avoid surgery. So the question for any test, a biopsy or a blood test, anything in medicine, if the result of the test is not going to influence what you do, then we probably shouldn't be doing the test. And so if we wouldn't trust a quote unquote negative biopsy and would be worried about a nodule and want to take it out anyway, then sometimes there's no reason to undergo the biopsy. But if there is a difference in treatment that the biopsy could influence, then certainly can help in many cases. So again, I sound like a little bit of a broken record, but it is very individualized when you get down to brass tacks. How to get a second opinion? Unfortunately, that probably boils down more to a question about insurance and access. In the U.S. in the year 2020, anybody can come to us. We do get patients who are self-referred, but I think most doctors are very open to bringing in expert second opinions, especially a rare and complicated disease like LMS. And doctors, not always, but often have pretty thick skins and aren't offended. So never hesitate to ask your doctor a question, especially if it's bothering you. If he doesn't or she doesn't have a thick skin, he should, or she should, and should not take any offense, certainly. And so, ask your doctor, how can we get a second opinion, just to make sure we're not missing something. To be honest with you, there was a little bit of excitement about lung transplantation for certain cancers, I'd say 20, 30 years ago, not really borne out by experience. So don't think too much about transplantation for any form of cancer, and sarcoma certainly among them. There are very, very rare cancers where we still consider it, but in general, it's not a great idea, and not a real option. Okay, so a little explanation. What we meant by VATS, this video-assisted thoracoscopic surgery, excellent description of it. The idea is that we, rather than spreading the ribs apart and getting our hands in the chest and looking directly through that big hole, we make tiny little incisions we leave the ribs alone. We sneak in between the ribs with instruments, cameras, and fingers, and look at a screen to guide us. There's something called robotic surgery out there now, and it's being heavily marketed in chest surgery now. The problem with robotic surgery is that there's no fingertip on the robot for the robot to tell you what something feels like. So I told you the finger is still the most sensitive technology that we have for detecting tiny nodules in the lung, and the robot cannot do that. So I would say if someone suggests robotic surgery for this disease, not a good idea. If you do minimally invasive surgery for this type of problem, metastatic sarcoma, definitely needs to be VATS or open surgery so that the surgeon's finger can feel the lung. Some surgeons think they have to operate just based on the CT scan if they're going to do VATS. That's also not true. So that's where it's a little harder to find a surgeon with a lot of experience in this area who knows how to feel the lungs through a VATS incision. Okay, I think that's most of it. Oh, and then one last question about whether a biopsy of recurrent disease can help identify new targeted options, what we call precision or personalized medicine based on the mutations that are found within a specific tumor. And it's certainly true that these tumors are not homogeneous, they're heterogeneous, which means that different parts of a tumor will have different genetics, and different metastases can certainly have different genetics. In LMS, to be honest, we don't yet have really good targeted options. When targeted therapies have been explored in LMS, it hasn't really borne great fruit yet. So there are a few more targeted options, not a lot, but a few more targeted options in other forms of cancer. This field is exploding though. We have many agents that do target specific proteins and specific mutations, and we're learning how to use those in different patients over time. Just hasn't become yet a really big part of treating LMS. So for that reason, really delving deep into the mutation analysis of recurrence may be interesting, may be revealing, may highlight an opportunity to be part of a more experimental program, like a clinical trial for a new agent that may be very exciting or very important to know about, but doesn't really guide approved therapy yet.
Any more questions?
Those are really great questions, though. I must say, very sophisticated group tuning in today.
Wow. Okay. Well, I just want to thank you, Dr. Mann. This was a wealth of information, and I'm sure it's going to help. I see a lot of head nodding. Yes. Yeah. Can we give them a virtual clap? Yay. I thank you so much. This is going to help a lot of people, and I'll have to check you out for lunch when I'm up on the hill there.
Sounds great.
All right. Thank you so much.
Thank you, Sharon, for coming on.
All right. Thank you, everybody. Bye.
Thank you.
Yeah,
Bye. Bye. Thank you, everyone.